A very good morning to all of you. So I'll be talking about corneal scraping, the right way to go. There are no financial disclosure. So corneal scraping, as we all know, is a superficial keratectomy procedure to procure samples from the corneal infiltrates. So what I'll be covering in this presentation would be why to do corneal scraping, when to do corneal scraping, and how to do corneal scraping. So why? It's the cornerstone to the management of microbial keratitis. So even experienced cornea specialists, when they rely on typical features of feathery infiltrates or a dry looking ulcer, etc., they can diagnose bacterial versus fungal correctly in only 2/3 of cases. 1/3 still you cannot come to a diagnosis even with clinical experience. Then the typical features of fungal keratitis such as satellite lesions, feathery margins, etc., are present in only 30% of cases, and the rest may not be that easy to make out based on your clinical examination alone. So corneal scraping is imperative. You do a smear gram QH which will give you a rapid clue to diagnosis to initiate the appropriate antimicrobial therapy. Then a bacterial or fungal culture will help you identify the causative organism and do speciation. And sensitivity, of course, in this era of emerging antimicrobial resistance, you have to tailor the management appropriately and identify drug resistance. Coming to the indications, when to do corneal scraping: central large corneal ulcers with or without stromal involvement, chronic infections, cases refractory to ongoing treatment, previous history of any surgery, post CXL, post LASIK, post transplant. You have to do a scraping and suspect infection. The index of suspicion has to be very high. Atypical clinical features such as radial keratoneuritis, feathery margins, satellite lesions, etc., that point towards a specific microorganism. Multifocal corneal infiltrates. These are the AO recommendations for when you should do scraping. So when can you avoid scraping and do an empirical antimicrobial therapy alone? Maybe in small ulcers less than 2 mm, not involving the visual axis, overlying epithelium is intact, there is minimal or limited stromal involvement, you can get away without scraping. But the rule of thumb should be that if there is a significant ulcer, you should scrape. Initial presentation prior to the start of empirical therapy is the right timing to do scraping. In case the patient presents to you late, often they would be on treatment from outside, still do scrape, especially in non-responding cases, and you can withdraw the use of antimicrobial agents for 24 hours, then scrape and restart the appropriate antimicrobial therapy. Also, if the initial cultures are negative and patient is not responding to treatment, it's another indication to scrape. Before you go ahead with scraping, you have to document the corneal findings. So a colored corneal diagram is what we teach our residents to document. Epithelial defect is shown by green, infiltrates by yellow, hypopion, and a photographic documentation as well, because it will also help you assess if it's responding to treatment or not. And progression or worsening, areas of clinically active margin, areas of maximum thinning, impending perforation should all be noted. Before you start scraping, counsel the patient, take an informed consent, explain the steps of the procedure. Just don't go ahead with a needle or a blade to the eye. Explain first. Patient comfort is important. Typically, scraping is done on slit lamp under topical anesthesia. Anesthesia in itself may be bactericidal, and topical proparacaine 0.5% has been shown to have the least bactericidal activity. So put the appropriate anesthetic drops, wait for a minute, and then start scraping. So which instrument to use? You have metallic instrument, you have swabs, each come with their pros and cons. So needles are very handy. So we all tend to do scraping with needles. They have a high risk of perforation, and the amount of material that you collect with them may not be appropriate. Then blades, 15-0 blade, Bart Parker blades, etc., disposable, sterile, easy to use. Sampling from the deeper layers is allowed with these blades, and they also in the process debride the ulcer a bit and enhance drug penetration. Then if you look at the Kimura Platinum Spatula, again a very useful tool. However, you need to re-sterilize between specimen collection, because you have to collect specimens for gram, for KOH, for bacterial culture, for fungal. Advantage is blunt edges and leaves a smoother corneal surface. Calcium alginate swabs soaked in appropriate transport media have a very high culture positivity. The disadvantage, they inhibit PCR yield in itself. However, they are associated with a lesser perforation risk. So in cases with thinning, you can use swabs as well. So purulent material and debris around the infiltrate should be discarded first. Scrape the edges and the base of the infiltrate. Exert mild to moderate pressure, multiple strokes in a single direction, and avoid areas of thinning. So here on the left hand side you can see a 15 number blade is being used to scrape the leading margins and the base, and on the right hand side a needle is being used, a 26 gauge needle. So as you can see, the needle does carry a higher risk of perforation and it's more risky. Then what do you do with the collected sample? You have to transfer the sample onto the glass slice to make direct smear. Area is pre-marked with a wax pencil on the under surface, and make to 3 to 4 smear, and discard the blades after the smear. Don't reuse them, use a new one for each. And then gram staining and QH mount is what is conventionally performed, 2 smears at least, and then GMSA acid fast smears are taken when necessary. So we all know the process of gram staining. It's based on the thick peptidoglycan cell wall in gram positive organisms that take a gram stain crystal violet, and in the thin peptidoglycan cell walls in gram negative it will decolorize, and counter stain is taken with safranin. QH of course you use to lyse the corneal material collagen, and you can see the fungal hyphae. Sensitivity and specificity: for bacterial, gram stain has a sensitivity of 61 and specificity of 84.9%. For fungal, it has a specificity of 99% but a sensitivity ranges from 30 to 98. For KOH, fungal 72.2 to 91% sensitivity and specificity of 99%. Then you have to inoculate the culture media, either direct inoculation, it gives a higher yield, or a transport media may be used. Viral and chlamydal cultures you are collect in Hank's balance salt solution. So various media are available, and direct plating when you inoculate a culture media do in C-shaped streaks. And if you are using a liquid media like a thioglycolate broth on the right, you have to put in the needle or the swab and don't reuse it, use a new one for the next one. So these are the various culture media available for different organisms. Direct plating of course is preferable. So we tend to bug our microbiology department that what's the report. Do know that it does take time. Aerobic culture you have to wait at least 7 days, anaerobic cultures 7 to 14 days, mycobacterial and fungal cultures 4 to 6 weeks before reporting as no growth. So have patience. Culture positivity rate is 24 to 77%, and a growth is significant if the organism goes on 2 different media. Same organism grown on repeat scrapes, culture consistent with the staining report, or confluent growth is observed at the site of inoculation on a solid media. Challenging situations: uncooperative patient, pediatric, associated desmetocele, deep-seated infiltrate, scraping may be challenging. You may need an examination under anesthesia for uncooperative patient and children. So just to summarize, why scrape? To identify the causative organism and tailor treatment, and check the sensitivity to whatever treatment you're giving. When to scrape? Almost all ulcers except for small central peripheral less than 2 mm ulcers. Anything else you have to scrape. How? Document, counsel the patient, give topical anesthesia, use metallic or non-metallic instruments. Just be aware of the pros and cons of each. Scrape the best base and leading edge. Gram, KOH, culture sensitivity, bacterial and fungal have to be sent. However, scraping may be negative. So what next? You have a host of other technologies that is beyond the scope of my talk. You have corneal biopsy, confocal microscopy, ASOCT, various adjuncts, PCR, and other culture methods are available nowadays in case you have scraping negative repeatedly. Thank you for a patient hearing.
Thank you, Manpreet, for detailing the, we see it a very small step in our management, but it's one of the most effective way to treat your infectious keratitis patient. If you have something in your hand that can guide you how to manage these patients, and properly done scraping and subsequent, staining them, getting a good microscopic examination gives you your immediate attention to change your antibiotic profile or start some new antibiotic for patient. And culture sensitivity will also give you another guideline of either modifying or continuing the same medication. Also, very, very important step in any infectious